Excellent. I'm Aaron. I'm from Australia. I'm one of the regional anaesthesia fellows currently at St. Paul's. Coming to the end of my time here, but have a wonderful close to a year now in Vancouver. Today, the focus of the talk is to talk about some regional anaesthesia options for focusing on indications for the foot and ankle, whether it's for surgery or you know, something that might be required in the emergency room, for example, that could benefit from regional. The blocks that we're going to focus on are the popliteal sciatic nerve block, and then I'll also talk through an ultrasound guided ankle block, which is probably is a very high utility block that is potentially underutilized, I think. So, I think you know, YouTube and digital resources, you know, present an amazing avenue for learning now, and a lot of the resources that I've used for this talk have come from the following YouTube channels. So, if you're interested, I would encourage you to check them out for learning. So, we'll start by talking about the pop sciatic block, and I think this is a good focus for the talk because it really is such a high value block. It will just kind of cover some of the anatomy briefly again, but as you can see, the sciatic nerve really supplies everything below the knee, excepting the small areas supplied by the saphenous nerve. So getting a good block of the sciatic nerve at this level can allow you to do almost anything below the knee, and we quite routinely do below knee amputations under just a popliteal sciatic nerve block and a saphenous nerve block, usually at the adductor canal. So it is very powerful. So I'll go back there. The sciatic nerve can be blocked at multiple levels, from the gluteal area down the thigh to the popliteal fossa. But I'm going to focus on the popliteal fossa because the nerve is quite superficial and easily visualized at this area, and that makes it quite amenable to be blocked. Okay. So the pop sciatic nerve block, we can provide surgical anesthesia or analgesia for anything below the knee. Made a point of highlighting that the saphenous nerve is actually quite important, although it's a small nerve that, you know, seemingly supplies a, you know, just this variable cutaneous territory on the medial side of the ankle and calf. It is actually quite important, and I've definitely regretted not blocking it on several occasions. It does actually give some innervation to the medial ankle joint and the distal tibia. So surgery that involves the ankle, like an ankle arthroscopy, for example, you'll definitely benefit from blocking this as well. The sciatic nerve block at this level won't cover a thigh tourniquet. So if your surgical procedure requires a thigh, sorry, you Canadians say tourniquet, is that right? If your procedure requires a thigh tourniquet, then you'll need a spinal or a general anesthetic or something else to provide some analgesia for the thigh. As I said before, the nerve at this level is usually quite superficial, so a standard linear transducer and the 80 millimeter block needle are usually sufficient for the vast majority of cases. This image just briefly covers some of the landmarks. At the popliteal fossa, usually around the apex, the sciatic nerve will bifurcate into its branches, the common peroneal nerve and tibial nerve. And it's usually around this branch point that we try and locate the nerve and block it there. Some of our landmarks are the popliteal artery and to a lesser degree the vein, but more so the artery. I think the next couple of slides are particularly important. Somewhat recent, I guess, understanding of the sciatic nerve involves knowing that it travels in a connective tissue sheath. We call it a paraneural sheath that is histologically distinct from the nerve epineurium. And it's quite a thick fascial layer, and really depositing your local anesthetic within this paraneural sheath is, I think, the key to a successful block, particularly a block for surgical anesthesia. This is just a little histological section of the branched common peroneal and tibial nerves, showing that the paraneural sheath is distinct from the epineurium, and there's a nice arrow suggesting that this might be a good location to drop some local anesthetic. Just a very quick point on all of the routine preparations that we would consider to be core components of safe and effective regional anesthesia. I'm not going to harp on about it, but those are all things to think about as part of when you are performing a nerve block. So we'll talk about positioning. The nice thing about a pop-sciatic block is it can be performed in a variety of positions, and your choice of position just depends on your comfort and ergonomics for both you and the patient. Limiting factors that might prevent a patient from adopting a certain position. And those positions are prone, lateral, and lateral can be with the patient facing away from you and you pushing probe into their leg, or the patient facing towards you and you pulling the ultrasound probe towards yourself, or in the supine position. In general, a prone position is the easiest for the operator. It's quite, I guess, ergonomic and easy to needle from that, but it can be difficult for certain patients to achieve and maintain a prone position for any length of time. Lateral is a good balance of all of those aspects, and supine is my least favorite, but certainly there are a number of operators who love to block the popliteal fossa in the supine position. I find that I get a lot of hand fatigue from pressing the ultrasound probe against gravity into the popliteal fossa, especially if the leg's not well supported. Then you're kind of having to support some of the weight of the leg as well. So this is just a quick sonoanatomy review. So if you start scanning the popliteal fossa, and firstly you try and locate the popliteal artery, and usually there'll be a nice nerve-like structure lying superficial and lateral to that. The sciatic nerve is certainly quite anisotropic, so you might have to really play with your tilt of the ultrasound probe. Usually tilting towards the feet might allow the nerves to light up. Usually some dynamic scanning, proximal and distal, should allow you to identify the branching point, or if you start too distally, it is important to identify the branch point to make sure that you are going to anesthetize both of these nerves. And if you start too distally and don't appreciate that, you may only cover the tibial nerve, for example, and completely miss the location of the common peroneal nerve, or worse, risk traumatizing it with your needle inadvertently. The common peroneal nerve can be sometimes a bit difficult to see. As you can see in this case, it does have some very large hypoechoic fascicles, and that's reasonably common to it. And that can sometimes be easily mistaken for some of the other hypoechoic structures that are less significant. And additionally, the two nerves can often demonstrate different anisotropy to each other, so they may require different degrees of ultrasound probe tilt in order to highlight each nerve individually. So once we've kind of identified this bifurcation point, we have to make a decision about where we actually are going to block the nerve. This analogy of a pair of pants with the paraneural sheath being the pants and the sciatic nerve being a trunk and a pair of legs is something that's kind of stuck with me for a while. You definitely want to get the local anesthetic into the pants, and that's going to give you the best chance of success. And the level you block it at is, all of these levels are reasonable targets. if you were to pick one, probably just at the point of bifurcation, so when the nerves have started to separate from each other and are close together but not quite touching, that usually it can be very amenable to be blocked at this level. It not only gives you an opportunity to pop your needle into the paraneural sheath in between the two nerves if that nerve orientation is favorable, that can allow you to safely enter the sheath without risking direct nerve trauma. But if you try and block the nerves too distally, then the paraneural sheath will have separated, and you can, if you aim to place your needle between the two nerves, you'll still be outside of the sheath, and that can be an easy mistake to make. So this little video just gives an example of needling from a lateral to medial direction, and you can see that the insertion point was actually quite deep, aiming superficially, and that's aiming to enter the paraneural sheath between the two nerves at a favorable angle. You can see how much tenting of the tissue is required. It is really quite a tough sheath, and there's quite a noticeable elastic recoil. You can see that first test injection was outside the sheath, and watch for the elastic recoil of the tissues that can help you visually confirm that you might be in the right location. Some of the following slides will help give us a better understanding of what correct spread patterns are. But as you can see, there's local anesthetic spreading almost circumferentially around the tibial nerve in this case, creating a kind of a very round filling of the pant leg, which is really the ideal spread pattern that we want to be seeing. And following this, they're scanning dynamically distally and seeing that the local anesthetic fills both pant legs. And that is really what you want to be doing to confirm for yourself that you're in the right place and that your block is going to be at least given the highest chances of success. As I said earlier, the paraneural sheath is really the key to a successful block. It really, visualizing this nerve is generally pretty easy. There's, unlike, for example, some of the brachial plexus blocks where there's a lot of hazards along the way, like other nerves or blood vessels, there's usually very little in the case of popliteal sciatic nerve block. The hard part is getting the local anesthetic in the right layer. It's pretty easy to be outside of the paraneural sheath and to be convinced that you are inside. And so you do have to really needle quite close to the nerves, which is, obviously risks going one layer too deep and having an intraneural injection, which is a horrible situation to be in. This slide gives some examples of what optimal and suboptimal spread patterns look like. If you were to deposit the local anesthetic just purely intramuscularly, you should just see kind of hazy expansion of the muscle area without any clear spread around the nerve. If you're through the epimysium but outside of the paraneural sheath, then you'll get a subepimysial spread pattern, which may be quite misleading, but often things that might help you there is that the whole nerve bundle might be pushed away from you. There won't be separation of the common perineal and tibial nerves or local anesthetic spreading between them. And if you scan dynamically, proximally and distally, you certainly won't see that local anesthetic filling those pant legs. It'll just mostly be deposited around the area you placed it, and it won't be tracking superiorly and inferiorly. And in contrast to that, if local anesthetic is within the paraneural sheath, you will see it kind of creating this nice round spread pattern, clearly delineating each of the two nerves, ideally spreading circumferentially around it, but that is not required, and it tracking distally and proximally within that sheath. Similarly, this second slide demonstrates the difference between a subparaneural and a subepimysial spread pattern with some of those points that I just mentioned. Now, with the subepimysial spread pattern, you will still get a block. It's And if your purpose is only to provide analgesia and you're having difficulty getting into the correct layer, and you're worried about causing needle trauma, you will still get an effective block with this. It just may take a long time for it to set in. And I mean, it can be more than an hour for you to get an effect, but it may not be good enough to provide surgical anesthesia. So if surgical anesthesia is your goal, then this sort of spread pattern is really what you should be aiming for. So a couple of points. Yeah, most people would require 20 to 30 mils of local anesthetic. The sciatic nerve being, a very large nerve, it is going to take a long time for the local anesthetic to soak in, even with fast-acting local anesthetic. So if you want surgical anesthesia in any sort of reasonable time frame, it is probably worthwhile to introduce a reasonable proportion of lidocaine into your mix. Now at St. Paul's, with our block room, we do a lot of our surgical blocks with just plain 0.5 ropivacaine, but we usually have at least an hour of lead time ahead of the patient going into the OR for that local anesthetic to really soak in and to create an adequate block. I think if you don't have the luxury of that time, then you'll be really, it would be much more prudent to put some lidocaine in. Otherwise, your chance of inadequate block density at the point of surgical incision would be reasonably high. And just a little point about post-block care. There is a risk of foot drop. I mean, the sciatic nerve block will create hydrogenically a foot drop for the period of time the block is in effect. And so managing that with some sort of support or splinting is actually quite important. Something we really don't think about almost at all, because our indications are for a surgical procedure, and nearly all surgical procedures leave the operating room with a surgical splint. But if you were to be doing this block for pure analgesia in the ward, or an emergency room indication, then thinking about that as part of your post-block management would be important. Okay. Try and quickly move on to ankle block. So ankle block is, it's one of my favorite blocks because it really gives you the opportunity to do 5 blocks for the price of 1. It's essentially, you're just going to be finding and targeting each of these 5 nerves with your ultrasound and blocking them individually. Now, back in the day, when I first started training, which wasn't really that long ago, but we were doing ankle blocks as a landmark technique, which was roughly a ring block of the ankle with the 2 deeper nerves, the tibial nerve and the deep perineal nerve, targeted separately. It was generally, we would, it was the kind of running joke that it was often successful, but the patients you did it in usually had an insensate foot anyway, so you didn't know whether it was the block or whether they actually needed it. They could have had their toe amputated without a block anyway, and they probably wouldn't have realized. And it sometimes did require quite a large amount of local anesthetic, and it was uncomfortable for your patient. Ultrasound can improve upon those points, certainly in the efficacy. When targeting the nerves directly with ultrasound, your effect should be very close to 100% in getting the desired outcome. And you can be much more sparing with your local anesthetic, which could allow you to potentially do bilateral ankle blocks for certain procedures if required, and still would be within a safe dosage range. It doesn't create a foot drop, which can be a benefit for ambulatory patients, and it won't cover any form of tourniquet, either a calf or thigh. Potentially your local anesthetic at this location is going to last a little bit shorter, and if you're after duration, you might be better off doing a pop sciatic instead. Brief overview of dermatomes. So superficial perineal covering the dorsum, deep perineal, the first web space, sural, the lateral malleolus down to the lateral aspect of the 5th toe, saphenous to medial malleolus, and medial aspect of the ankle, usually not heading down as far as the first toe, kind of stopping in a variable distribution around there. But the most important nerve is really the tibial nerve that supplies the calcaneal and medial lateral plantar nerves. and the vast majority of the deeper structures of the foot. This is a little diagram of lower leg osteotomes. Really, most of the bones and joints of the foot are going to be supplied by the tibial nerve, excepting some of the dorsal aspect, which is supplied by the deep perineal. So the point there is that if you are going to do an ankle block for a foot procedure, it's very rare to not require the tibial nerve. And that is usually the largest nerve. It will take the longest time to get an adequate block density, so you should generally target it first as well. The nice thing about ankle block, and I guess it, as a rule applies to a lot of different blocks, is that nerves can sometimes be difficult to see, but they travel close to other structures which are often more easily identifiable or anatomically reliable. And the ankle block is no different. So we'll cover each of those landmarks as we go through each block quickly. It's a small area, so a smaller footprint transducer can be beneficial, but if you don't have that, just a standard linear transducer is fine. Most of the nerves you can get away with 3 to 5 mils of local anesthetic, except for the tibial nerve, which definitely needs a little bit more volume. And there's a few needling options. You could go the standard block needle, shorter block needle attached to a syringe with a longer extension, or a sharp needle directly attached to a syringe, or a short extension are some options. The utility of using a sharp needle in this case is that there's often some thicker fascial layers. They're all very superficial, and it can be actually quite challenging to get a blunt needle into these areas, and it can be more painful for the patient. A sharp needle mitigates some of those problems, but this certainly adds an extra risk of contacting a nerve with a sharp needle is much less desirable than contacting it with a blunt needle. So you have to be able to manage that risk well. In terms of positioning, being at the foot of the bed on some sort of wheelie chair allows you to move around and to block on both sides of the ankle. I personally like to have the ankle bolstered up and kind of floating in space, similar to this, which allows you to get very posterior for the tibial nerve and needle from a posterior anterior direction. Okay, tibial nerve. So the landmark for the tibial nerve is the posterior tibial artery. So we want to be scanning around the medial malleolus or proximal to the medial malleolus, looking for that posterior tibial artery. The other things around it, it usually sits in a kind of triangular fascial compartment, bounded by the flexor retinaculum and sitting on the belly of the flexor hallucis longus muscle. So getting the local anesthetic into this triangular compartment is the key to getting this block adequately covered. Let's see what's happening here. So this is your tibial nerve next to your artery, and sometimes the tendon of flexor hallucis longus looks a little bit like the nerve, but if you're scanning dynamically proximally, you'll see that the tendon just disappears and becomes the belly of the muscle, and the nerve will still stay nerve-like. Okay. And this is an example of tibial nerve being blocked, needling from a posterior to anterior direction. And you can see that once in the compartment, spread around the nerve is achieved. And I think in this video, they go on to redirect the needle a few times. It's not strictly necessary. Just putting the local there will be effective. The usual order I go in is starting at tibial and then just moving in a clockwise direction around the ankle. You don't have to block all of the nerves, I should say. Like, you can think about the procedure that the patient is having and just target the specific nerves. For example, if you're having your fifth toe amputated, then tibial, superficial perineal, and sural nerve would be all that you require. So the saphenous nerve follows the saphenous vein, and the nerve is often very difficult to see without local anesthetic around it. But if you place local anesthetic in the same fascial layer as the vein, you'll grab the nerve grab the nerve as well. Sometimes putting a tourniquet around the the thigh and using, sorry, the calf and using a bit of gravity can help make the vein a little bit more easily identifiable. So in this case, you can see the vein and a kind of an idea of where the two fascial layers are, and in this case, the needle is just brought in and local is deposited on either side of the vein without clearly searching for the nerve. And that should give you an effective block. Okay, so moving on to the deep perineal nerve. The landmark in this case is the anterior tibial artery. And you can see in this case, the point at which we're blocking is when the tibial artery, anterior tibial artery, is sitting on the distal tibia, creating a nice platform. This is a nice little picture of two views of the anterior tibial artery. This is a little bit more distal and this is a little bit more proximal. Your scanning would generally plop your ultrasound probe down, look for the artery, and then scan proximally until you find the base of that distal tibia, creating a nice smooth platform to trap the local anesthetic around the nerve. The nerve is probably that structure here. It can be on either side of the artery, and if you scan proximally, you can often see the nerve cross over from side to side. So it's a pretty quick clip, but essentially you're looking for a periarterial injection at this location, and you'll usually start to see the nerve if you haven't seen it already once some local anesthetic is around. Okay. In the superficial perineal nerve, the landmark is the fibula. The way I was taught it was that you scan proximally up the fibula until it looks like a mountain. And then if you're a person sort of running off the mountain and you left off into space, you would kind of leap into the superficial perineal nerve. I don't know if that's strictly correct, but that was the story that one of my mentors told me, and it's kind of stuck with me. What you're really looking for is intermuscular septum that departs from this point on the fibula and reaches superficially between extensor digitorum longus and peroneus brevis. At a superficial point on this intermuscular septum, there'll be a triangular fascial layer where the superficial perineal nerve lives. And as you scan distally, the nerve will superficialize and leave the investing fascia and travel outside of it before it arborizes into its little terminal branches. And this is a nice little clip that demonstrates that. So we can see that intramuscular fascial septum. This is that triangular area with our superficial perineal nerve, and we can now see it leaving and becoming superficial. I'll just play that quickly again. Okay. There's a school of thought that advocates not blocking the nerve within that triangular compartment, as it's a small compartment and you can risk some compression of the nerve with the local anesthetic. And it is also quite difficult to get the local correctly within that compartment and not get it just into the surrounding muscles. So instead, potential safer option is to block the nerve just at the point when it's left that deep fascia and it's superficial, but before it's branched. And that's what the nerve is here. That's what these people are doing. And lastly is the sural nerve. The sural nerve, the landmark for that is the short saphenous vein, and both the vein and the nerve travel initially in the posterior calf, superficial to the gastrocs and Achilles tendon, and then move laterally. So we're going to scan for it in the kind of just superficial and posterior to the lateral malleolus, and look for a fascial hammock that's created between peroneus brevis and the Achilles tendon. And this little space, you should find the little nerve. You can see that nice little hammock. So just putting the local anywhere within this area will give you a good block. Okay. I think in this case, it looks like this person's needle goes straight through the short saphenous vein, but just going to choose to ignore that. Okay. So that was kind of a slightly fast-paced presentation on this area. Just thought I'd open it up to any questions or comments, and if there's nothing, I've got a couple of other things I can talk about to fill in the time.